Hello everyone, I'm Rachael Lowe from Physiopedia, and today I am chatting to Chris Worsfold. Hello Chris.
Hi Rachel.
Thank you for joining me today and having a chat today. I've reached out to you because when I search for neck pain on our friend Google, you pop up quite high at the top of the list. I know you do a lot of teaching and you have a big interest in neck pain, so I would be really keen to talk to you today about all things neck pain. I hope that's all right.
Yeah, thanks for inviting me. Yeah.
Good. Before we go into anything clinical and exploring knowledge about neck pain, maybe you could just give us an introduction to yourself for people out there who have never met you before, just so that we can know a little bit about yourself, who you are and what you're up to at work.
Okay, yeah, thanks. So I'm a musculoskeletal physiotherapist, and I have a mixed musculoskeletal caseload in private practice. I'm based in Tonbridge in Kent, in the southeast of England, and I basically work full-time there. And about 10 years ago, I decided to specialise and develop a sort of a specialised private practice in neck pain, but also with the idea of teaching and setting up a centre of excellence in that area, really. So it meant reading all the papers on that area and textbooks, etc. So whiplash comes into that. I was attracted to complex kind of presentation. So that's really where it started. And so I have a specialist neck pain clinic running alongside my mixed musculoskeletal caseload. And over the years, I've taught a course for about the last 8 years, and I've presented at conferences on neck pain. And it's really translating the research into clinical practice. So I've done that sort of the hard work in that, and that's what I present on my course and at conferences. Over that time, I was asked to represent the CSP when the government were reforming the whiplash medico-legal system. I represented them in Parliament in 2013, and also attended Ministry of Justice meetings, and ended up on a small company set up by the government. And I stepped down from that a year ago now, 18 months ago. And so mainly it's basically focusing on all the research and putting it into practice since then. Recently I've contributed a couple of chapters to an undergraduate textbook on musculoskeletal physiotherapy. And I'm just preparing some papers on where my teaching's at the moment, sort of masterclass type papers.
Very good. It sounds like there has been a big focus on neck pain for maybe the past 10 years. So I'd really like to delve into some of that knowledge today. And it's really nice to talk to someone who's still in clinical practice as well. I talk to a lot of researchers and things, so it's nice to talk to someone that's in clinical practice. And I'm hoping I can pull a few things together for us and everyone that's been learning out there with us today. So I would like to start with asking you, for physios that are working with individuals with neck pain, what are the most important things that those physios need to know and need to be thinking about when they're working with those individuals?
So I think any starting point's got to be about red flags before we move forward. So if I think of headings, I think red flags, and we can talk about that. And then I think the emphasis has got to be on rehabilitating neck pain. Really, we've focused on quite passive modalities in the past, perhaps quite abstract exercises as well that aren't based in, don't have a functional approach. Perhaps they're not based in the way we use our head and neck each day. So I think that would be sort of my second emphasis, would be on really basing it on a rehabilitation type approach. And the third thing would be, I suppose, we've talked about neck pain. It needs to be clear, whiplash is a very different condition, and it needs to be really treated separately to neck pain as a presentation, because the research tells us it's a very difficult problem to help. Using physiotherapy approaches, and we can discuss that. But I think those are the three big things, I think, would be red flags, neck pain, rehabilitation, and
Where's the evidence with whiplash? Okay, so let's start with red flags then. Talk us through red flags.
So one of the things that keeps me awake at night, and I wish I'd studied sort of the ankle instead, is the fact that you've got all these blood vessels going through the neck which feed your brain, and you've got the spinal cord. So it's a double whammy, really. And we've got to think, okay, what pathologies can affect those blood vessels and what pathologies can affect the spinal cord, and how might they present in day-to-day clinical practice? So really, the big things are excluding cervical arterial dysfunctions, like cervical arterial dissection, is someone having a stroke, are they at risk of a stroke? The other stuff is excluding like a myelopathy, cervical myelopathy, a spondylotic myelopathy, where there may be a lot of degenerative change and a narrowing of the spinal canal that's putting pressure on the spinal cord. So what sort of symptoms would we expect from that? And also excluding fracture as well, because that can put pressure on the spinal cord as well. So I'd say those are the top three. Do you want me to go on and sort of talk through those, or have you discussed those already? Or?
Yeah, let's just. So obviously with fractures, I think we have quite a good model for working on the cervical fractures with the Canadian C-spine rule. So that's quite easy for us to follow that rule. I think with the other two, cervical myelopathy and CAD, what sort of approaches should we take to ruling those out?
Yeah. So I think if we talk about the blood vessels first, cervical arterial dysfunction or dissection, we're talking about people presenting with, they may have a wide variety of symptoms arising from, it's basically interruption of the blood supply to the brain, isn't it? So you can imagine there may be neurological type symptoms. They may be in the body, or they may be in the head and face as well. But a hallmark in the literature is that if you're having a cervical arterial dissection, you'll have a pain in your head, plus or minus your neck, that's unlike anything else you've had before. It may or may not present like that, but that's generally a good starting point. And there may or may not be neurological signs and symptoms, so dizziness, double vision, drop attacks. You may have paresthesias in the face, cranial nerve problems as well. So if someone's presenting with those kind of symptoms, then hopefully, we would want to screen and keep those at the forefront of our mind when we're with any neck pain patient, and particularly if the neck pain is new in onset and maybe it is more severe than we'd expect and maybe involves head pain as well.
With those individuals, how do we manage them? Do we refer them on immediately to a medical specialist, or can we treat them?
So I think it's important to refer on. If you think someone's having cervical arterial dissection, then they need to see a medic for urgent investigation. So.
Okay, good. And then moving on to the myelopathy.
Yeah, so myelopathy, I don't think it's that common in day-to-day clinical practice. But again, we need to be vigilant, because it's not something that there's much evidence that we can help the problem, and also it's something that needs to be monitored. The recommendation at the moment is for 6 monthly follow-ups. So we're talking about narrowing from a degenerative cervical spine perspective of the spinal canal, which may put pressure on the spinal cord. So you can imagine spinal cord pressure could lead to motor problems with the feet. So you may have a stumbling, drunken-like gait, wide-based gait. You may have problems with fine motor control in the hands as well. So zips and buttons may be a problem. And there may or may not be radicular-type pain or radiculopathy in the upper limb. And in terms of testing, we're talking about things like Babinski's and clonus in the lower limb, and Hoffman's sign, flicking of the finger, and a hyperreflexia. Maybe it may be a positive finding as well. So it's really keeping your mind open to the possibility that this may be a problem. And again, if you find these signs or symptoms, just describe, then a referral onwards back to the GP just to highlight the fact you found them.
Okay, and then cervical spine fractures, we have the Canadian C-spine rules. I think they're well validated and okay for us to use.
Yeah, it's good stuff. Yeah, I have an infographic on my blog of this. I think it's a very useful tool, and it's it'll pick up a fracture. It's a good test to use.
Yeah. Okay, good. And what other things should we just be looking out for before we move on in our management strategy?
Well, those are the ones. That's what I look for. Yeah, I mean the other non-neck specific ones would be things like someone unwell, weight loss, recent fever. If you're thinking discitis, so the usual stuff. Yeah.
Okay, good. So we've ruled out red flags, and then your second heading was about rehabilitation, neck pain rehabilitation. Tell us your thoughts on that.
So my own sort of pathway with this was, obviously I taught a course for many years, and it was very focused on whiplash. And a lot of the whiplash and the neck pain literature sort of started emphasizing a sensory motor approach, so looking at balance and proprioception of the head and neck, and eye movement control as well. So we'll talk a bit about that in a moment. But the tests were kind of left at that level that you test them at. So, you test proprioception and you'd use that as a treatment, or you'd test balance and you'd use that as a treatment. So it was the same for the muscle performance literature as well. You do a deep neck flexor tests, or you do some neck strengthening, and it's kind of left at that level. And it dawned on me slowly after reading quite widely around the rehab literature and looking aghast at the sort of protocols you have for hamstring rehabilitation or ankle sprain rehab or anterior cruciate reconstruction. The Aspetar, the Sports Medicine Centre of Excellence, these kind of videos, protocols they have with very strict criteria for return to play and lovely rehabilitation pathways. We have nothing like that for the neck. And it occurred to me that we're sort of stopping rehabilitation of the neck at this impairment stage. So an analogy for ankle sprain would be, do you get people in with ankle sprain and just mobilize a joint and get them maybe doing dorsiflexion only and some standing on one leg? But of course you don't. You very quickly move on to functional movements, and you would strengthen the ankle in all directions, a multiplanar rehabilitation. So it occurred to me it's not happening in neck pain. And indeed, when you reflect on why we move our head and neck, it's because we're nosy and we want to have a look around us. It's always goal orientated, and every movement is in the body, isn't it? So not only that, those movements are encoded in our central nervous system with the goal in mind. Everything's completely goal orientated. So we've got to think, well, are we really rehabilitating neck pain? Or are we simply sort of paying lip service to these research findings that we have about poor proprioception? Well, practice that. Poor one leg balance, practice that. So it's about the rehabilitation concept, which I'm teaching at the moment, is about really addressing the fact that we move our necks to look, to listen, to smell the coffee, to smell the roses, to look at something in a shop window that attracts us whilst we're walking down, to cross the road and move our head left and right, to groom, to shave, to put on mascara. That's the way we use our necks. And perhaps rehabilitation needs to get there as soon as possible. And it's okay to do these impairment level tests, the deep neck flexor tests, maybe some endurance tests. Like you would with a knee, you might do some static quads to encourage it to fire, but very soon you'd get up, do some stepping, some hopping, some trampette work. You'd challenge it more. And that's really where I want to take the rehabilitation. And that's the idea. So it brings in strength and sensory motor rehabilitation, as well as the other factors like range of motion and accessory movements, etc., etc. Because if you reflect on the literature, the epidemiological data tells us we're not doing very well with neck pain. It's in the top 3 disabilities, leading disabilities worldwide for 25 years. It's been there. It's not shifted. Neck pain's recurrent and episodic. If you have it today, you're 50% plus likely to have it in a year's time. So we've got to step back and think, well, what are we doing? Are we rehabilitating it? So that's the kind of concept that I'm talking about when I talk about rehabilitating it.
So from that, leading on from that, can you describe to us some of the practical rehabilitation approaches that you would take from this impairment level that we kind of are at to moving on to making a more efficient, more effective management strategy for the long term, so that we can address these things like the recurrent neck pain and the poor epidemiology that we have of neck pain?
Yeah. So the research evidence takes us this far. So if we thought of a recurrent ankle sprain, someone came in, we'd go, right, let's look at the strength. We'd manually muscle test the strength. We'd look at one leg balance. We might do something a bit more challenging functionally. And I think there's literature to support the same approach with the neck. And
that literature that we're talking about, that kind of a lot of that, are we talking about the work of sort of Childs and Fritz and the treatment-based approach and all the evidence and sort of evidence review that's gone into that sort of classification system and management approaches?
Yeah, so I'm thinking more of sort of Julia Treleaven's work with sensory motor work and Deborah Fallon and Gwen Giles' work with deep neck flexors.
Yeah.
There's deep neck extensor work, and there's some work on gross strength, for want of a better. So it's really coming at it from that perspective.
Okay.
So if we kind of assess the neck, what do we come out with? And thinking of the ankle sprain analogy, what do we find in people who have neck pain, clinical features, experimental features? So we find that people have altered muscle performance, so there'd be reduced strength, there'd be reduced speed of movement, there'd be increased rigidity, like a stiffening of the motor pattern. There'd be delayed firing of some of the muscles, so you get a sluggishness and an alteration in the way the muscles work. So you get superficial musculature take over and the deeper musculature tend to switch off. And from a sensory motor perspective, you get altered postural stability, altered eye movement control, so tracking of smoothly moving objects can be difficult. And we also get altered proprioception, as we do with most pain in parts of the body. So really, if we're looking at rehabilitation, if we can measure any of these things, so we could do deep neck flexor tests, and that's a valid test, and it's a useful clinical test. There's more and more research supporting this as an assessment and treatment approach. We can look for gross strength by doing some resisted tests of the head and neck or some endurance type tests. And we can look at proprioception using a laser attached to the head to see if the individual can return to a neutral head position with their eyes closed. We can look at eye movement control, see if there's impairment there. And we can look at postural stability. So those are the impairment levels. So we'd often find some of those amiss with a neck pain, person suffering from neck pain. And then we'd seek to address those as a sort of a foundation building block towards moving on towards function. And then the functional work might simply involve moving across a room, looking right and left quickly, or sitting, moving the head right and left as quickly as possible. We might keep the head still and rotate the body underneath, or walking across a room, just looking at a fixed point on one side and then walking back again. Or you can drop an object on the floor to one side of the person, so they have to look at it and walk past, turn around and walk back. So that's flexion and rotation. So these kind of things we're doing all day, every day. It's not difficult to come up with a short list of stuff that's important. And that's critical to day-to-day function as well, that we can then move on and utilise in a rehabilitation programme. And that's true use of sensory motor aspects and motor and muscle performance aspects, isn't it?
Yeah, absolutely. And so the impairments that you're talking about here do they occur in everyone with neck pain?
No, okay, so the sensory motor complaints of dizziness, unsteadiness, these subtle feelings. We're not talking about a vertigo where the room's spinning or they're spinning around the room. It's often a very subtle symptom. You're talking about a third of neck pain patients and three-quarters of people who've had a whiplash injury will report some form of sensory motor impairment. And the muscle and muscle performance work. I mean, I think it's, if you've got some neck pain, it would be surprising if you didn't have some neck weakness as well. I'd be very surprised not to find that in an individual. Yeah.
Okay, so that's kind of covered the sensory motor approach to rehabilitation of neck pain. Is there, for that third of patients that present with these impairments that you've been talking about, is there another sort of rehabilitation line for the other 2/3 of people that we should be thinking about that takes them that step further from just the basics that we seem to, that the evidence has got to so far?
Yeah. So I think the third is to do with the sensory motor disturbance. So the other 2/3 may well have some muscle performance impairment. So they may have reduced strength, reduced endurance, and exercises that target the deeper muscles, the stabilizers, may be impaired as well. And there may be problems with speed and movement of the head as well. I mean, it's bizarre sitting here in 2017, who rehabilitates speed of head movement? And yet it's something we need to do to cross a road. It's a simple thing to test how quickly someone can move their head. So that's the point, is sort of switching the muscles on and off quickly and feeling confident and trusting the neck is an important part of rehabilitation.
Yeah, so I guess what you're saying is, we do all the deep neck flexor work, and we might even give them some strengthening exercises against gravity or something, but we need to be moving on from that and thinking more about exactly what we're doing with the head every day, and I guess specifically for those individuals as well, what they're doing at work and what they do all day long, and making up rehabilitation protocols and sort of exercises for them personally, for the things that they specifically do and the movements that they're specifically lacking or struggling with.
Yeah, I'd agree. I think the problem's been, and I've taught hundreds of people over the years, and I like to have a good discussion when I teach. There's still this sense, which is understandable, that the research kind of trickles out from the universities, and we sort of follow what the research tells us to do, but we don't sit and look at the neck and go, it's a multiplanar movement, and it's moved because of the sensors, and that should be our starting point. So we end up with quite bizarre treatments like the deep neck flexors. Now, when I go into hospitals and do that, maybe 5 or 10% of people will put their hands up and go, yeah, I use it regularly. And most people go, well, I stopped using it. And you stop using it because there's no context for using it. It doesn't really, a light doesn't come on when you do it. This person doesn't come back going, they were fantastic exercises. I feel fab. You don't really know what's happening when you do it, So I think to embed it in more of a rehabilitation process, as we're discussing, makes more sense. Because it was only a few years ago that Jochen Schomacher and Deborah Faller went round the back of a patient and decided to have a look at the deep neck extensors. And they're often a surprise to people. But I joke, no one's written about the side flexors.
Yeah.
It's astonishing we're having this conversation even. No one's written about them. No one assesses them. They're there. And indeed, when I test patients' side flexion endurance, it can often be really poor. So why wait till the research comes out, Because that's what we're doing. We're not really looking at what the problem is, I think. And the research suggests, some of the largest research trials in whiplash have only just looked at a flexion exercise or a flexion extension exercise. And it would be bizarre if you had an ankle sprain rehabilitation project that was funded for millions of pounds that just looked at plantar flexion and dorsiflexion. You'd be laughed out of the house. Non-weight bearing as well, And the more recent work that's been done out of Scandinavia has shown multiplanar strengthening in chronic whiplash has shown slightly better outcomes. So it's just that idea of, right, I'm going to strengthen this thing in all directions it moves, and
So I guess what we're kind of saying is, I guess what's kind of coming out here is that, the evidence to a point to where we're at with the evidence is good, and it's good to follow, and it gives us a good guideline for working with individuals with neck pain. But we need to go further than that, and we need to look at each person as an individual and see exactly what they're missing and address those problems to rehabilitate them for their own circumstances.
Yeah, couldn't have put it better myself.
Yeah. Good. Yeah, good. I think that's a really nice thing to get people to think about, because we do point people in directions of following what the evidence says, but actually we need to look at the person that's in front of us.
Yeah.
Okay, good. Well, that's good on that rehabilitation side. Now, your third thing that you mentioned was whiplash, and we've just sort of moved into whiplash a little bit, but you're saying that whiplash shouldn't really come under the heading of neck pain, that it's completely different. Just talk us through your thoughts on that a little bit.
So I think the bottom line is that the outcomes with traditional approaches, as we're discussing a sort of a rehabilitation approach with neck pain, they're much more positive outcomes. The effect sizes are much larger with neck pain. When we look at these approaches with whiplash, it shows very little difference, if any, to a sort of wait and see group or a group that just got one education and advice session. So we've got to view this as a very different sort of beast. And the reasons why the outcomes are poor, we don't really understand. What we do know about whiplash is there is a subgroup of patients who have very poor outcomes. And it looks like we can identify that group of patients early on at about 6 weeks, 4 or 6 weeks after the injury. And I think the role of the physiotherapist is to triage and identify those who have this high risk of poor outcome, without being too alarmist about this. And the kinds of presentation that you'd expect in a person who has at risk of poor recovery is someone that the most important thing with the trauma view from whiplash is this presentation, a post-traumatic stress reaction would be part of the presentation. So they may have nightmares or flashbacks about the accident, intrusive thoughts. They may have difficulty stopping thinking about the accident. And they may be in a hyper-aroused state. They may be irritable, jumpy, sweaty palms, this kind of scenario. So if this is going on, if there is this post-traumatic reaction and it's not settling by 6 weeks, the evidence suggests they need to be seen by a psychologist for some cognitive behavioural therapy. And this would be an obstacle to physical recovery. And indeed, the literature shows when they're treated in this way, it improves pain and disability and allows some movement forward in the rehabilitation. So that's the most important thing. That's top of the list when we're talking about whiplash, really. And I think if you have screened for these people, they're often people who have widespread pain. They may present with central sensitization, so they'll be tender in areas that haven't been injured, and the shins, the front of the shins, are used in the research literature, and that's useful just to apply some pressure in these areas. And they're often they often experience pain and tenderness there, and they may have irritable bowel syndrome, migraine, past history of musculoskeletal aches and pains, as well as evidence of this sensitized state that they were in before the injury. And they may demonstrate fear of movement, fear of re-injury. They may feel something terrible has happened to their neck. They may be catastrophizing. So they want you to fix the problem. They exhibit passive coping strategies, taking lots of pain relief. And they may be ruminating on their condition all the time, thinking about it all the time. And really worried about the future and about what this terrible injury that's occurred to them. So there's a spectrum of presentations there, aren't there? The most important thing is to identify the post-traumatic stress, and they need referral on. And it will depend on the skill of the clinician, really, whether they feel they can take on the fear or the catastrophizing element, because there are techniques and approaches that are successful, and the literature in whiplash suggests if you use these approaches, it can be helpful with these more psychosocial variables.
So our role there is to identify these individuals who are at high risk of poor recovery, and we can do. So you were saying we can do that by week 6 after the injury, the traumatic injury, and so you say that we need to refer on to a psychologist. What if we don't have that available to us? Can we treat these people ourselves?
Well, I think the evidence is quite clear. I mean, we're talking about a psychological problem here that needs professional help.
Right.
So the screening tool used is the impact of event scale, and there is a cutoff on that score, above which the suggestion is that a person would need some sort of psychological input. Below that, or with catastrophization and fear of movement, I think those things are right up a physiotherapist's street. If they're appropriately trained and confident in using those approaches.
And what sort of approaches are those? Is this when we're talking about cognitive behavioural therapy, or is it something else?
Yeah, so I mean, for the catastrophization, you're talking about using cognitive behavioural approaches. So it's cognitive restructuring. It's getting the person to look at these thoughts, these automatic thoughts, maybe write them down. You can discuss them. You're bringing them out into the open, and you're talking about, are they useful things to keep going around your head?
Yeah.
Are they appropriate? Are they valid? And you have some great discussions about this, in a supportive environment, and it can make huge differences. And the fear work is fantastic. Some of the work over the last few years with whiplash patients has demonstrated huge changes in pain and disability just by using in vivo fear exposure approaches. So getting people to maybe list a hierarchy of things they're frightened of doing and getting them to do it.
Yeah.
Very much cognitive functional therapy, that kind of mix of that, getting the person on side, addressing maladaptive cognitions and experientially addressing fear.
It's my understanding that that approach is more effective if we are trained in that to apply that approach. Is that correct?
I don't know, to tell the truth. I mean, I teach it on my course and hopefully give people, if they're not trained in that area or thinking about that area, that give them a first rung on the ladder to start to discuss it with patients. But obviously, this is a very, it's an interesting area, isn't it, in terms of training? So yeah, I don't know whether outcomes are better if you're formally trained, to tell the truth.
But I guess then what I'm saying is that we shouldn't run into it blindly. We need to have some knowledge of how we're going to manage this situation with our patients.
Absolutely, yeah.
Okay, so we've covered the 3 things there. You've come up with some really interesting approaches, and we've covered 3 headings that you mentioned at the very start when we started talking. Is there anything else in when we're working with individuals with neck pain that we haven't talked about that's really important for physiotherapists to have knowledge of or to bear in mind when they're working with these people?
No, I think that covers it all. I mean, I would also say that with the whiplash input, the rehabilitation of the neck approach is also important. But I think in the past, traditionally, we've utilised too much treatment, and I think in a sense that can make people worse. And I think it's important to give realistic outcomes to people about it can take maybe longer than 3 months to get better, but in that time you'll be getting better, so that they're not surprised that it is taking longer, because they often think there's something wrong and they need to keep checking back with people because they're not better yet. So I think that's an important point. But I would also assess in the same way I said for the neck pain. So I'd look at the bigger picture, the sensory motor stuff, the muscle and motor stuff. But that's self-management work, and that's something someone can do. It empowers them, it improves their confidence. And so that's not left off of the picture. But you can see there, it's a complex, it's not straightforward. There's a lot of skill involved, as there is these days. There's more and more stuff coming into the mix, isn't there? It takes a lot of skill to pick out the priorities and what you're going to examine at any one stage.
Yeah.
But certainly with whiplash, my take home would be we need to step back, and maybe we've been doing too much of this kind of passive, hands-on, abstract rehabilitation and move into more of a functional domain with also one eye on screening for risk of poor recovery. But I don't think there's anything else I'd add overall. Have you got any questions on?
Good. Oh, well, Chris, it's been really interesting to talk to you. It's definitely a something to add to all the evidence that is out there, which is really interesting, and I'm interested to explore more and understand more. So thank you so much for sharing that with us and with everyone today. You've mentioned your course a few times. I know there's going to be a few people that now want to come on your course. So where can people find out more about you, what you do, and come on one of your courses?
So thank you. Yeah, I have a blog, and it's chrisworsfold.com, and I've got the upcoming lectures there.
Okay.
And there's sort of ongoing CPD. I try and update that a couple of times a month. All the stuff I've been mentioning today is on there, videos and different summaries of what we've discussed. So.
That's excellent, Chris. Thank you so much. I hope that some people will join you on your course and come and learn about some more of these techniques. But for now, thank you very much for talking to us today. I know you've got another patient coming in very soon, so I won't keep you. It's been a pleasure to talk to you, and thank you for sharing your knowledge.
Thanks very much, Rachel. It's been a pleasure. Thank you.